Good evening, everyone, and thank you very much to the Scleroderma Foundation for having me across for the second time on this podium. It is indeed a privilege. I'm not going to have a PowerPoint presentation and so on, though I'm actually looking at the beautiful presentation made by Prasandeep. I was wondering whether I should have done that. But I'm usually the style where I like to talk. I like to explain stuff. And so maybe some may like it, some may not. But let's take it as it goes. So the topic that I was given was the fact that let's talk about stem cells. So why stem cell? Let's start from why stem cell. And the reason is because of the fact that we do know that the treatment of scleroderma or systemic sclerosis, which is actually the full name, is less than satisfactory at this point in time. Most of the evidence is on just cyclophosphamide. There is some evidence for the skin and lungs for mycophenolate. Methotrexate, the evidence is mainly for the skin and the joints for those people who have arthritis secondary to systemic sclerosis. And that's it. You end there. There is nothing further. Then we started doing rituximab for people with bad interstitial lung disease, and we did find that there was some improvement, but there isn't a concrete trial to prove that rituximab will be the answer for all the scleroderma problems. You do it more as an option when nothing else really works. So that's where we are. And naturally, when you have a morbid disease with a decreased lifespan overall, what you want to do is you want to offer the patient, it's a downhill course. And you have a patient who is constantly suffering. Most of the times you can't, as a doctor, if you're involved with your patients, you can't even tolerate to see their suffering. So at the end of the day, I have a dedicated scleroderma OPD, and at the end of the day, Tuesdays is our scleroderma OPD. And at the end of the day, you're actually mentally tired because you've seen a lot of patients who are actually suffering nonstop, one after another. And that's how it goes. And you keep offering them, you keep encouraging them, and there isn't really anything that that you feel hollow inside. So that's where stem cell therapy actually came up as a hope. Now, how did that come about? That came about because patients of lymphoma and leukemia, who also had some autoimmune diseases, were given stem cell therapy, and they found that the autoimmune disease also seemed to quieten down. And that's what prompted the research about 25, 30 years ago, that why not we tried independently of doing it for the patients with autoimmune diseases. And in autoimmune diseases, the maximum data that's available is for multiple sclerosis, which you people may or may not have heard of, but at least the sclerosis word is familiar. The only thing that you need to know is that multiple sclerosis affects the spinal cord in the brain. So that's worse, right? You're talking about a wheelchair-bound life till such time, and the patient losing control over his nerves, and hence the problems. And then you have scleroderma, which is systemic sclerosis. This is where you have the maximum data. You have had some patients in autoimmune diseases where rheumatoid arthritis, it was tried, or systemic juvenile idiopathic arthritis, where it was tried. There is some data available for lupus and dermatomyositis, but very little, very small data. And most of the data is not from India because we're so busy catering to a large population that we really don't have a systematic registry where we actually document every patient of systemic sclerosis or lupus or dermatomyositis who actually comes in. And so you don't have the data to be able to prove that, yes, so many were positive, so many were negative. Most of currently the information that I'm going to give you actually once again comes from the international databases, either the European or the American. Interestingly, the European database is much more precise, at least at this point in time. You have trials coming in from the US, but the registry is much more organized from the European database. And what are we looking at? What is the outcome? Surely, in systemic sclerosis, when you use autologous stem cell transplant, and you do find that there's a significant positive response, but there are a few caveats. Now, what is autologous stem cell transplant? You take your own blood, you filter out the patient's blood cells are filtered out. You use the positive stem cells, which are done by a filtered machine called leukapheresis machine, and you filter out the native stem cells, the adult stem cells, which are there. And then what you do is you land up using high-dose chemotherapy and trying to kill practically the entire immune system of the systemic sclerosis patient. You try to kill the entire immune system with a high dose of chemotherapy that used in cancer. They also try to do in some cases total body irradiation. So you radiate the whole body because you may not succeed completely by doing it just with cyclophosphamide chemotherapy. You may not have killed all the cells. And once you've done that, you turn around and infuse the filtered stem cells that you have actually collected from the same patient, and you put them in back. And the patient, of course, is in isolation, and it's roughly expected that about 2 weeks down the road, you will have some amount of regeneration of white cells coming from these fresh stem cells, which go into the bone marrow. And then you land up have the bone marrow once again regenerates. And it turns around and regenerating your white cells. It starts with the neutrophils and the platelets. And this patient is critical. This is the critical phase where the patient is an open target for any and every viral infection. And you continue, you turn around and presume that your transplant, your stem cell transplant is now succeeding, or you are going to possibly expect that the patient will now sail through, is when you had 3 consecutive days of the neutrophil count rising above 500. Mind you, you're supposed to have anywhere between 4,000 and 7,000 in a normal person. But when you've burnt all the cells, you're down to 0 or less than 100. And that's when you have no infection, no immunity at all. And that's when, if you have had some latent viruses in your body, if you have had some latent infection in your body, that's going to take the happiness out of everybody. But that's, so there's a lot of isolation, extreme isolation. There are a lot of antibiotic covers that have to be put in place, antiviral covers, and post which you just continuously monitor some twice a day how the white cells are actually improving. The white cells are, and the platelets are improving. And once you reach a stage where the platelets are for 3 consecutive days more than 20,000 and the white cell counts are consecutively more than 500, you can expect that the white cells will now engraft themselves. That's the medical word for it. And the platelets will pick up. Now, once that happens over a period of time, you have the improvement that can be expected. Now, this is what is the purpose of doing this? The purpose of doing this is reconstitution of the immune system, because when you use a high dose chemotherapy and when you actually turn around and you are irradiating the body in certain cases, but otherwise you're using high dose chemotherapy, you're killing away all the diseased cells. You're killing away all the inflamed cells which are transmitting inflammation and thus worsening your disease. And then you can expect that now the naive cells that you've put in are going to turn around and help improve the immune system and induce tolerance. And we are seeing that, right? So we are seeing that there's improvement, which is why the interest in stem cells has really taken off now, not only across the globe, but definitely in India as well. And we are looking at the fact that more and more patients would possibly try and opt for it. So then what's the caveat? Why not just have that completely? First, what I need you to understand, if you need more technical details, of course, a hematologist or a transplant hematologist is the right person to give you on the procedure. I'm not the authority on the procedure of it. But the pre and the post, is what I would really like you people to understand. So the pre part, of course, you know that you're going through a disease, but you need to understand that, is this a completely safe procedure? No, it's not. I've just given you the entire process of the stem cells, and you've understood that you're an easy target for infections. That's one. The other thing is what is called transplant-related mortality, which is within the first 100 days post the transplant. And during that time, the incidence when it started with trials used to be close to 10%. They've kept on improvising on that, and now they claim that it's somewhere around 6%. So, but we can presume that it's about 6 to 8% mortality within the first 100 days, and that's called transplant-related mortality. Now, what happens really? What are the causes? Apart from the infections that we speak about, the more important disease-related causes, and that's why I compliment the designer, and I think Rashmi must have designed this program because she got Rath to speak before me, and he spoke about the heart. And now I'm going to talk about the fact that the biggest risk in a stem cell scleroderma case undergoing a stem cell is transplant-related mortality due to cardiac involvement. So it's just perfectly aligned. Obviously, you people have done a fantastic amount of homework to have aligned the talks like that. But what you need to understand is the fact that when you have cardiac involvement, the mortality is much higher. That's one. And scleroderma does affect the heart, as Rath has already explained to you. And so what we are dealing with is a fact that there's ideally a narrow window of opportunity. And you need to step in. You cannot do, or you should not be opting a stem cell transplant for a person who has a compromised cardiac function. So this is the first thing that you need to understand. And sometimes by the time you realize that there is a cardiac involvement, it's a little late by the time you realize it. And so a screening process for the pulmonary hypertension, the right heart failure, the left heart failure, all of that has to be flawless. You can't turn around and rely on a 2D echo and turn around and say, my cardiac function seems to be okay, because a 2D echo may not be reliable. You can't rely even on just a dobutamine stress test and turn around and say that, well, I have documented everything. You need to be able to do beyond that. And non-invasive cardiac testing may not work. And so every patient with systemic sclerosis who's thinking of stem cell transplant needs to undergo right heart catheterization first and get an accurate measurement of what really is your pulmonary artery pressure. This is the first point. Now, if you've got it correct, then would you be completely okay? No, you won't be, because this one, once again, is when the patient is lying down, the patient is already admitted in hospital, maybe a few hours earlier, and you have then done the right heart catheterization with the patient without exertion. So now how are you going to know whether you've got a flawless procedure? So what you do is, during the right heart catheterization, you also give a fluid challenge. And that fluid challenge, if it shows that the pulmonary artery pressure goes up, but the heart is not able to take up the fluid challenge, within 10 minutes, you infuse a large amount of saline, then once again, you know that now you've unmasked something there. And the last part, which again, Dr. Rath spoke about, is the fact that the cardiac function in terms of the microvascular perfusion. And so you need to do a cardiac MRI. And if you have your cardiac MRI sorted out, if you have your pulmonary hypertension sorted out, if you have, the electrical disturbances sorted out, then you know that a high dose of cyclophosphamide, which is known to be cardiotoxic, you will possibly sail through that. The postulation is that the transplant-related mortality is because of the fact that the cardiac function gets affected by the high dose of cyclophosphamide and all the other drugs that you use. So this is what you need to understand. And then the other aspect that you really need to consider is the fact that the risk of infection. So the reconstitution, once you've got this in place, what can you expect? So suppose everything is successful, what do you expect? You expect that you're going to get better, obviously, but you need to know what to expect and management of expectations. Don't be under the impression that stem cell transplant is a cure. It's not a cure. It's not going to reverse your disease. It's the best treatment modality available to induce a remission, but what is already been damaged is damaged. And you can expect improvement in the skin for sure. That's been proven for beyond doubt that the skin definitely improves. But does the skin improve only because it takes away the fibrosis or it takes away the inflammatory component of the fibrosis and so on and so forth? That would require you to do a skin biopsy pre, post, look at the amount of fibrosis versus the inflammation, so on and so forth. We aren't there yet, but just take it for a fact. You don't need to go into root cause analysis, but yes, you can expect that the skin will surely improve. That's one. The inflammation in the lung will go down. So the PFT will show improvement in terms of forced vital capacity, which is your ability to take in air. Does it improve the diffusion, the DLCO? May or may not. You don't have evidence there, but you definitely have this much there. Can you expect that the food part will improve? Not necessarily. It's not going to improve. If you have a renal involvement, then if you are going towards a deterioration, you might be able to stabilize it. This is what you can expect. Calcinosis, the evidence is mild. Whether the calcinosis will go away or not, we don't know, but further improvement, further deterioration will not happen. So this is called expectation management. You need to know exactly, one, you're dealing with a process which is going to help you in the long run for sure, but it's not a cakewalk. It's not going to be an easy process, definitely in the first 1 year, because your immune system takes months to recover. Don't expect that just because within the first 100 days you've sailed through with the neutrophils in place and the platelets in place, you're there. The lymphocytes are still coming up, and that takes months to come. So you are a target for infection even after you are out of that problem. But what I'm referring to is the transplant-related mortality. Yes, in the long-term process, you're much better off compared to what you have today. Is it the go-to solution? Always and always? We don't know yet. So you need to understand these parts about the stem cell therapy. Of course, the expense depends center to center. The ballpark figure, I was talking to my hematologists, and they haven't yet done we have a bone marrow transplant unit, and we do a lot of bone marrow transplants, and we're starting Scleroderma stem cell transplant program in the near future because we already have all of it in place. But, the ballpark figure for their disease is about between 12 and 15 lakhs. We don't know what it's going to be for Scleroderma. People say it goes up to 20 in certain, if you have complications, it can go higher. So you're going to spend that kind of money. You must go in with a complete picture about the fact that, is that a cure, all intents and purposes? Are you going to be like how you were before? No. Are you going to deteriorate further? No. Doesn't look like you're going to deteriorate further. Is that a rule for all times to come? No. Why? Because the data is available for 5 to 6 years, number one, and stem cell transplant has not resulted in 100% of patients' response. There have been non-responders as well, but majority, and the numbers are small, mind you. When you're talking about databases and you talk about numbers like 600 patients of Scleroderma on the registry, you really can't base your data on just 600 patients. So we have to see what happens. But yes, it has been shown, and I don't know whether can I share my screen? I want to show you one, just a table.
Absolutely, doctor.
I want to show you something which is maybe you people might like it in terms of knowledge. And this is what I wanted to show you. This is what I want you to see. And I am going to show you the graphs here. Look at these graphs.
We can't see the
So
screen,
you
doctor.
have, intention to treat population, and you can see for sure that in the red line, the transplantation patients are doing better than the cyclophosphamide patients. This is comparison is only been
We can't see your slides.
Sorry?
We can't see your slides.
Oh, you can't see my slide. Oh, I am so sorry. Is it evident now, Dr. Dharma?
Not still, doctor.
Not yet. I think you have to give him permission to
The
share
permission
screen.
is already there, sir.
Okay, fair enough. So let's not, I wouldn't like to take away your time on this one and impinge onto the other speakers' time. But what I wanted to show you actually,
Dr. Kaushik, seems like your screen is coming up.
Dr. Kaushik? Dr. Kaushik, his screen is frozen.
I think he's going to join back.
No, he's already here, Dr. Kaushik.
can you hear me now?
Yes, sir.
I apologize. I have no clue. Can you see this now?
No, sir, we can't.
No, just go ahead, Kaushik.
Okay, fair enough. So what I wanted to show you was that the graph that has been looked at over 6 to 7 years of longitudinal study for the patients who underwent the stem cell transplant definitely showed that the graph was not on a downward climb, as it was downward, but way better than what you had with the conventional cyclophosphamide. Now, the comparison in all the studies has essentially been, all the trials has essentially been with cyclophosphamide. Has the comparison been done with cyclophosphamide plus rituximab plus whatever? No. But really, at this point in time, on the basis of the evidence that we have, we don't know very, very clearly that yes, the stem cell transplant in the long run, the hemopoietic stem cell transplant, as it is called, and particularly autologous is what we are doing now, we are finding that the data is in favor. And if you can take the caveat ahead, so then what are the precautions that you take? The precautions that you take is you have a rapidly progressive systemic sclerosis, which is progressively going downhill. And that's when you know that if you don't intervene very quickly, you are going to get into trouble as far as this patient's lifespan is concerned. That is where you intervene rapidly. What is preferred is that you select patients who are rapidly progressive disease within the first 4 years. If you find that it's within the first 4 years, those are the candidates. If you look at the male sclerodermas, they have a worse prognosis. The female sclerodermas, they seem to do better. You need to have a good cardiac function. You need to look at your pulmonary artery pressures. Look at them that the mean pulmonary artery pressure is 25 or less. If you have a rapidly progressive skin disease where your Rodnan skin score is rapidly rising, or if you have a Rodnan skin score which is already high, these are the candidates where you know that they're going to have a long-term prognosis which is not good. And that's when you would consider looking at a stem cell transplant for you to expect a positive result in your favor. Usually patients in the younger age group, less than 45 years is what you would opt for. So these are the take-home messages that I would like to leave behind. We do have problems. We don't have a complete foolproof solution, but this is the best that we have. The data is encouraging for sure, but the selection has to be very, very strict. If you don't have a stringent selection criteria, you can land up in all sorts of complications, and maybe your outcome will be much worse than, and when I say much worse, it's going to be negative in case you haven't taken into account all these factors. This is where I'd like to stop. I'll be happy to take questions if you have any.
We are not opening up for questions today, doctor. We have a
Okay.
long lineup.
Fair enough. Fair enough. Fair enough. So thank you very much. Thank you for a patient listening.